Well, good afternoon, everyone, and welcome to day 3 of MS Connect. My name is Andrea Dunn. I'm the host of This is MS, which is a new podcast we launched this year. The podcast was created with support from the MS Society of Canada to share stories of inspiring people who have either been diagnosed with MS themselves or have been touched by the disease in some way. So you can subscribe and listen for free on Apple Podcasts, Spotify, or wherever you listen to your favorite podcasts. Just look for This is MS. I am pleased to be your moderator for today's session. As we move into the presentation this afternoon, I would personally like to thank each of you for investing your time into learning more about MS and MS research. Now more than ever, it's important to build on the momentum we have created through MS research and to continue to push forward to discover future breakthroughs that will positively impact the lives of Canadians affected by MS. We would like to say a special thank you to our sponsors for making this conference possible. So thank you to our lead sponsor, Roche Canada, and contributing sponsors, Biogen Canada, Bristol Myers Squibb, EMD Serono Canada, Novartis Pharmaceuticals Canada, PendoPharm, Sanofi Genzyme, for providing the financial support to make this virtual conference possible. Now, questions can be typed in the question box at any time throughout the session, and I'll keep an eye on those and prepare those for the Q&A that's coming up. If you are posting on socials about the conference, make sure you use the hashtag MSConnect, as well as tag the MS Society Canada. Now, this session is being recorded and will be shared at msconnect.ca. The MS Society of Canada is proud to present this afternoon's research session, Cognitive Dysfunction in People Living with MS. I'm thrilled to introduce today's speaker, Dr. Anthony Feinstein of University of Toronto and Sunnybrook Health Sciences Centre. Dr. Feinstein is a professor of psychiatry at the University of Toronto. He has a PhD and a master's degree through the University of London, England. His expertise is in the neuropsychiatry of multiple sclerosis. This is best understood as the behavioral consequences of MS. His research has been supported by the MS Society of Canada, Canadian Institute of Health Research, and the Progressive MS Alliance. Please welcome Dr. Feinstein.
So I'm going to speak about cognitive dysfunction in people with multiple sclerosis. These are my disclosures. I have a number of aims to appreciate the prevalence and range of cognitive difficulties experienced by people with MS, to understand the real-world implications of cognitive dysfunction, to understand how computerized testing can make valid cognitive assessments more widely available, to appreciate the significance of cognitive reserve in determining current cognitive function. I'll spend a few minutes just discussing the effects of cannabis on cognition and the brain changes that are linked to this, and then close off with a few slides talking about treatment options for cognitive dysfunction. So my first slide is entitled Prevalence of Cognitive Impairment According to Disease Type 25 years later. And why 25 years? Because going back to the early 1990s, Stephen Rayo came out with a seminal paper showing that cognitive difficulties affected about 40% of people with MS. But back then, there was no distinction between primary and secondary MS, and the data didn't include people with clinically isolated syndromes. What we now know, 25 years on, is that indeed the rates of impairment are in the 40%, but they vary considerably according to disease course. So you can see here that about 1 in 3 people with clinically isolated syndrome has impairment. The numbers go up to about 40% with relapsing remitting MS, and as high as 70 to 90% for people with the more progressive forms of the disease. These are the most frequent kinds of cognitive deficits. Processing speed is considered the quintessential cognitive problem in people with MS, but there are certainly high numbers of individuals with difficulty with visual memory, verbal memory, working memory as well, and also a degree of executive dysfunction. These cognitive problems have very real implications for real-world functioning, and you can see this in this cartoon here. We have something called the Barthel Index, which looks at activities like bathing and unshelving food, opening containers, using utensils, using appliances, even something as simple as making a bed. And you can see that the individuals who are cognitively impaired have greater difficulty across all these tasks over here. So cognitive impairment casts a long shadow in the lives of people with MS, affecting very basic day-to-day functions. It's also an important reason why people forget to take the disease-modifying medication. And here we can see that there are many reasons why people don't take their drugs, but forgetting to administer a disease-modifying drug is the biggest reason. And this is almost surely linked in many people to cognitive impairment as well. How can you assess cognition? Well, there's a single self-report screening questionnaire, there's some brief batteries, there's a more comprehensive measure, and there's also something that is a consensus guideline document that we follow in terms of cognitive testing. So it goes like this. There's a single self-report measure on the market. It's called the Multiple Sclerosis Neuropsychological Questionnaire. It contains 15 questions for the person with MS, 15 questions for an informant. It has reasonable sensitivity and specificity. Interestingly, the informant responses are considered more accurate than the person with the disease. We know that individuals with MS are not the best judges of their own cognition, but someone who's lived with them for a year or more, who knows them well, can often give you a better indication of how that person is doing cognitively. We also know that people who complain a lot of impaired cognition may be depressed. So we have to be careful of this. And I see this in my clinical practice all the time, that people come in, they're worried about their cognition, they complain to their neurologists, and we test them, and they're in fact intact. But the problem is that they're depressed, and this makes them more aware of what they perceive to be cognitive deficits, not always accurate. This is now the recommended brief screening battery, the BICAMS, the Brief International Cognitive Assessment in MS, 10 minutes to complete. It contains the Symbol Digit Modality Test, the Brief Visual Memory Test, and the California Verbal Learning Test. When you want a more comprehensive battery, as we often do for research purposes, we've got the MACFIMS Consensus Guideline. This is Minimal Assessment of Cognitive Functioning in MS, and it contains tests of processing speed and working memory, the PACET, the Symbol Digit Modality Test, tests of memory, the California Verbal Learning Test for verbal memory, the Brief Visual Spatial Memory Test for visual memory, a test of executive function, a test of visual perception, and a test of language, attention, and executive function. This whole battery takes about 90 minutes to complete. The mini mental state and the MoCA are not good measures of cognitive impairment in people with MS. They lack sensitivity to impairment. The Symbol Digit Modality Test has emerged as the sentinel cognitive marker of difficulties in people with multiple sclerosis. It's a very simple test. This is what it looks like. The person is presented with a piece of paper with symbols in a random order. There's a code here with numbers 1 to 9, matching 9 different symbols. The individual has 90 seconds to match these symbols with a number according to the code. It's a test of processing speed with a small component of incidental visual memory. It's got excellent psychometrics. It's brief and it's cheap. It's patient-friendly. That's really important. People with MS do not mind doing this test. Conversely, they don't like the PACET, which is a much more difficult task. The Symbol Digit requires minimal equipment. It's easily translated. It's part of numerous consensus guidelines. It's sensitive. It's valid. And as you will see, there are computer administrations. However, one of the queries about the test is, well, what's the ecological validity like? I mean, if you do badly on this test, does it reflect real-world functioning? And in fact, this is a critique of all cognitive tests in general, that you can show deficits in your office, but how does this translate into real-world difficulties? Because when we test, we put the sign up outside the door, quiet please, testing in progress. And so we're creating an environment in the office that in many ways is far removed from the environment that people have to work in. They might be busy and boisterous and all sorts of distractors. So I want to share some data with you showing you how we tested this. To what degree do distractions impede a person's ability to complete cognitive testing, and how does it reflect on their cognition? So we took the symbol digit and we created a computerized version. And this is how it looks. So you're looking at a computer screen. You've got a code over here, numbers 1 to 9, 9 different symbols. Here you've got the symbols in a different order. And a buzzer starts, and your task is to match the symbol with the number as quickly as possible. And when you get to this symbol over here, the diamond, which matches to number 5, this line goes empty, and this repeats 8 times. But this is an analog of the SDMT. But now we brought in real-world distractors like this. And because this is computerized, we could control the presentation and the volume, and we could make sure that every individual got the distractor at the exact time and for the same duration. And these are what the data looked like. So individuals completed this test. They also completed a detailed cognitive battery. And we see the results here. Here we've got people with multiple sclerosis, 99 individuals. Here we've got a group of healthy controls. This here refers to each one of the cognitive tests. Test of visual memory, verbal memory, the PACET, the symbol digit, test of executive functioning. And you can see every time you see stats like this, there are very significant differences between people with MS and healthy controls. The MS individuals do far worse. When we have a look at the SDMT, the traditional version, the one I showed you at the beginning, the pencil and paper version, about 30% of people with MS fail it. When we give them the computerized version, about 37% fail it. The moment we bring in distractors, for example, the car horn sounding, the failure rate goes up to 47%. There's a very significant difference between the traditional version and the computerized version with distractors. And we see it here in the cartoon. Here we've got healthy controls. Here we've got people with MS. We have time on this axis, time in seconds. Here we've got the 8 iterations of the test. You can see that in healthy controls, even in those we have no multiple sclerosis, when you bring in distractors, the solid line over here, the performance slows down. Here we've got the healthy controls without distractors. Here we've got with distractors, and you can see they're slower. When you look at the MS group, they are significantly slower. So in general, people with MS are doing the test a lot slower. But you bring in the distractors, and you can see the difference between these two lines is a lot more than it is over here. And so distractors are having an excessive effect, as it were, on people with multiple sclerosis. And I want to show you some really interesting developments that we have in my lab. I've spoken at length about the importance of the symbol digit modality test as the sentinel cognitive test for people with MS. And one of the questions that comes to me frequently from my colleagues in neurology is, well, how can we bring in this test into a busy clinical environment, into a neurological clinic where there is no neuropsychological expertise, that don't have psychometricians to do the testing for them? How can we introduce a test like this into an environment like that? And so I got together with bioengineers at the University of Toronto to see whether we could develop a fully computerized, automated SDMT that has no tester. In other words, the computer takes over the testing. And we were able to do this using voice recognition software that is now within the public domain and made available by Google. And so this is what our test looks like. You will see an individual in the top corner over here is one of my research assistants doing the test. So you sit down in front of the screen, and the computer welcomes you as follows.
Thank you for taking the SDMT cognitive test. First, I need to confirm some information.
So the voice you hear is the computer, and you can actually give the computer a voice, whether it's a male, female voice, whatever the accent is. So we gave it this particular voice. This is my student over here.
Please say your unique case ID.
1123,
What is your current age in years?
25,
What is your sex?
male,
How many total years of education have you had? Please add up years of primary school, high school, and university or college education.
18.
So just to repeat, this is the individual talking to the computer, and the computer is, through voice recognition software, picking up what they're saying and entering the data for us.
Please make any correction if necessary. Speak start to begin the test.
Start.
First, we need to make sure you can see the screen well. Please come closer if necessary. Can you read these numbers here for me from left to right?
5, 6, 8, 3.
Great. Your vision is good for the...
So really important, we have to make sure that our individual has sufficient visual acuity to see the screen, and the computer is just taking them through a Snellen chart over here and very quickly tested their vision.
The test. Here you see we have 2 rows of boxes, one above the other. The bottom row is filled with numbers 1 to 9. The top row is filled with 9 different symbols. Underneath there are 9 more boxes. These will be filled with 9 symbols. Your job is to use the symbol digit key here at the top and verbally say what number goes with each symbol here in the bottom row. For example, in this case, you would say 6, 4, 2. Please continue and finish the rest of the trial. The symbols will no longer be highlighted during the test.
3, 8, 1, 7, 9, 5.
Okay, so the interest of time, I'm not going to run the entire test, but you can see the degree to which the computer has taken over testing completely. And what we were able to show is that this computerized simple digit test has excellent concurrent validity compared to the traditional SDMT, both for people with multiple sclerosis and healthy controls. You can see a very tight association between the 2 tests. Interestingly enough, that when we completed the study, we asked individuals, what did you prefer? Do you like being tested by a human or by a computer? And the majority of people actually chose the computer for reasons that are not entirely clear to us, but we think might be related to the fact that if you feel you're doing badly in a test, it's easier to do it in front of a computer than in front of another person. So we now know that the simple digit modalities test is a very important test for people with multiple sclerosis. This is a recommendation that was recently made by a consensus group of individuals who work in the area, basically stating that at a minimum, every person with multiple sclerosis should at baseline have a SDMT, and if possible, repeat the SDMT once a year, look at their cognition. Let me shift gears and talk a little bit about intellectual enrichment and cognitive reserve, because we know that these are protective factors with respect to cognition. Data from different diseases like Alzheimer's, Huntington's, Parkinson's, MS show that environmental enrichment can ameliorate cognitive decline, and environment enrichment comes through things like exercise and intellectual pursuits. Animal studies show that an enriched environment can modulate neurodegeneration, demyelination, and glial activation, and it can regulate neuroinflammation. And this can aid synergistically in rehabilitation. So intellectual enrichment, comes from your premorbid IQ, which I'll speak about, but leisure pursuits are also important. You don't want a life of all work and no play. And there's this wonderful quote from Victorian Times by this best-selling author, Samuel Smiles, who said, "All work and no play makes Jack a dull boy, but all play and no work makes him something worse." So you really have to try and find this balance. But working hard and having good leisure pursuits and playing hard is good for one's brain as well. And this enriched environment comes from things like reading and music and intellectual endeavors. So James Samofsky, who's done a lot of work in this area, has this nice topical review with his colleague Victoria Levitt, asking what protects patients from cognitive impairment. And certainly there's evidence to show that intellectual enrichment is important, but the other important factor is larger maximal brain growth. So let's look at each of these. So intellectual enrichment over here, this is your lifestyle. Our vocabulary reflects, excuse me, our general knowledge, and we acquire this through good education, our occupation, and what we read. And longitudinal research shows that these kind of variables, your education, your occupational attainment, contribute to our vocabulary independent of childhood intelligence. So we're born with a certain intellectual capacity, but we can certainly boost that through things like reading and having an enriched environment in which we grow up. And this can be protective in terms of cognition. So we see that as the disease burden goes up, cognition can come down. But in the context of high reserve, this can be somewhat protective. And the same is true for maximum lifetime brain growth, which is estimated from head size. This is based on the premise that people with a larger brain can lose more brain through atrophy before they reach the threshold at which cognitive deficits become apparent. And so these individuals are better able to withstand neurologic disease that may cause cognitive difficulties. And we see the exact same model over here, but as disease burden goes up and we have cognitive status getting worse, in those individuals with greater maximum lifetime brain growth, there's a protective element to their cognitive abilities. So now a few words about brain imaging and cognition. There are multiple brain MRI metrics that we can look at in terms of our search for correlates with cognitive impairment. And this was a study that looked at measures of atrophy and lesion burden as it related to cognitive difficulties. And the result was quite clear. The one MRI metric that emerged as a robust predictor of cognitive difficulties was third ventricular width. Brain parenchymal fraction, which is also a marker of brain atrophy, was also important, but not as powerful as third ventricular width. And we can see here that lesion volume is also important, but once again, not as important as this particular variable. And you can see that the associations here with indices of cognition, whether it's a single digit or the PACET, or indices of verbal or visual memory, are really quite strong, particularly for the single digit. This is a robust correlation of 0.71 between third ventricular width and performance on the SDMT. So what is it about the third ventricle that's so important? Well, when you look at your brain anatomy, and here we've got a coronal slice, what sits either side of the third ventricle is the thalamus. And as the thalamus atrophies or gets smaller, so third ventricle width increases. And the thalamus, we now know, is sensitive to involvement in people with multiple sclerosis. The thalamus is an important relay area in the brain in which multiple neural pathways pass through it. And so when the thalamus starts shrinking, it can affect many of these neural pathways, and by extension, having a negative effect on cognition. And that will show up as atrophy of the third ventricle, which we see very nicely in these images over here. Here we have an individual with relapsing remitting MS. Here we have a person with secondary progressive MS. Here we can see the third ventricle over here, and the width has increased significantly in the more progressive form of the disease, because sitting either side over here is the thalamus, which is shrinking. And so the third ventricle becomes a proxy of thalamic atrophy, and this is linked fairly robustly to cognitive impairment. Some thoughts about MS and cannabis, because this is really relevant to my clinical practice now. Not a clinic goes by in which I don't have multiple individuals asking about cannabis. We know now that about 20 to 60% of people with MS use cannabis regularly. By that I mean often daily, sometimes multiple times a day. That cannabis can have a negative effect on cognition, and I've put up a number of my publications, funded by the MS Society, by the way, indicating that cannabis, particularly THC, can have a negative effect on cognition. We also now know that these deficits might be reversible if the individual with MS stops using cannabis. And we know that cannabis can affect functional connectivity in the brain, thereby causing cognitive difficulties. And I can show this to you quite nicely. This is a test of memory, working memory. A person is lying in an fMRI scan, and they have a button box next to them, and they're told, just press the button when you see a letter X. So the letters come along. The moment the X appears, you push the button box. In the more complex task, the one-back task, you are told to push the button if a letter repeats itself. So the moment a letter repeats here, L, L, that's when you press the button box. In the more complex two-back task, you're instructed to push the button box only when a letter is repeated once removed. So here the letter D is repeated, but only after the letter L comes between it. That's when you push the button box. So now we can record accuracy. We can also record the speed with which you press the button box. And we know that in the context of cannabis use, people with MS struggle with this test. And here we see brain activation in this particular task for the two-back, the more complex task. And what we see over here, and you can see this, you don't have to be a brain imager. Here we've got individuals who are using cannabis, and here we've got individuals who don't use cannabis. Both groups have multiple sclerosis. And you can see in this group over here, there is significantly more brain activation in doing the task. And indeed more intense activation, as indicated by the brighter colors. Orange and the reds show intense activation intensity. And so what seems to be happening is that in individuals who use cannabis, these neural networks are shut down. They're not as activating as intensely, and that can lead to cognitive problems with cannabis use. And you see this very nicely in these cartoons over here. Here we have those who don't use cannabis. Here we have the cannabis users. Here we have the 0-back, the 1-back, and the 2-back task. And each one of these lines represents a brain region that activates during this particular task, this memory task. And you can see that as the tasks become more complex, brain activation increases. But then when you get up to the 1-back task, for cannabis users, there is no further activation in certain brain regions when it comes to the more complex 2-back task. It's as though neuroplasticity is now at its limit in the context of cannabis use, that the brain plasticity has become impeded by cannabis. In the non-cannabis users, you don't see that. But as the task becomes more complex, you see increasing brain activation from 0-back to 1-back to 2-back. And with this, you get a faster response and a more accurate response. So, one has to be careful of cannabis use, particularly THC, in people with multiple sclerosis. I believe that the CBD variant of cannabis is safer, and you're not going to get these kind of cognitive deficits with CBD use. So let me conclude now with some thoughts about how do you treat cognitive dysfunction in people with MS. Well, a Cochrane review shows that medication, pharmacologic intervention is not helpful. So things like donepezil, that's a drug used for memory enhancement in people with Alzheimer's disease. This doesn't work. Supplements like ginkgo, a drug like memantine, ribostigmine, another drug that's used in Alzheimer's dementia. This is not effective in people with multiple sclerosis. So no convincing evidence that any of these medications are going to help individuals with MS who have memory difficulties. What about your disease-modifying therapies? In principle, these should work because we know that disease-modifying drugs reduce T2 and T1 brain lesion volumes. They may slow the progression of brain atrophy. They can decrease inflammatory activity within the brain. So for all these reasons, there should be some cognitive benefits. However, there are many methodological problems with disease-modifying therapy studies looking at cognition. The biggest is that cognition is often a secondary or even a tertiary outcome measure, meaning that these studies were not designed to look for cognition. The primary outcome measure was things like walking, ambulation, not cognition. These studies often just brought in a single cognitive test, which was an exploratory measure. There was no indication of the patient's cognitive status at entry. So important. If you're going to be doing a cognitive study, you don't want to be testing people who are cognitively intact. You want to be looking at those individuals who are impaired to see whether you can bring about an improvement in these individuals. And the studies were not powered with cognitive parameters, so they didn't have perhaps the right sample size for this. And the observational studies of disease-modifying therapies, the vast majority are non-randomized, small samples with different clinical characteristics, and the assessment tools weren't the most accurate. So the results need to be viewed with caution. So have a look at this. Here we have 3 drug studies, disease-modifying therapies, eculizumab, fingolimod, dalfampridine. Really good sample sizes in these 2 studies, well over 1,000 patients. Here we've got 3 studies that are cognitive rehabilitation studies, not drug studies. And you can see much smaller sample sizes. Here we've got the effect size. Now, effect size refers to How effective has the intervention been? To what degree do these two groups differ, your treatment group versus your placebo control group? And effect sizes are as follows. Anything that's around about 0.2 is small, effect size of 0.5 is medium, 0.8 is large. This tells you the degree to which the two groups differ. So when you have a look at effect sizes with these drug studies over here, you can see that the effect sizes are none too small for daclizumab or fingolimod. With alfampridine, it's a medium effect size. But when you look at cognitive rehabilitation, we can see that the effect sizes are much more robust, 0.7, 0.8, 1.57. So what you see over here is that cognitive rehabilitation is a much more effective way of dealing with cognitive difficulties than these disease-modifying therapies. This doesn't, of course, mean that these treatments are mutually exclusive. People should get disease-modifying therapy because it could help your multiple sclerosis. But you should not rely on DMTs alone to treat your cognitive difficulties, because we now know that cognitive rehabilitation can be effective in helping people with MS who have cognitive problems. And it can help with memory and with processing speed. You can give it as a group. So for example, if resources are tight and you can't bring in individuals, but you want to treat as many people as possible, you can give cognitive rehabilitation to groups of people with multiple sclerosis, providing you group your individuals according to the same level of deficits. You can now give cognitive rehabilitation by a computer. We are doing this now in a very large study funded by the MS Society looking at cognitive rehabilitation in people with progressive MS. It's a study that's run from my lab in Canada, but has centers in the United States, United Kingdom, Italy, Belgium, and Denmark. And we are using a cognitive model that's computer-based, something called ReaCom. There's also an app that can be used for cognitive rehabilitation, with some good data from this. And finally, I'd like to just say a few words about exercise. We know that exercise is good for us. It improves our cardiovascular status. It's good from a cardiovascular perspective. It's good in terms of trying to manage high blood pressure and things like that. But there's now some evidence to suggest that exercise might help with cognition as well. And this is a study of individuals with progressive multiple sclerosis. Once again, cognition was not a primary outcome measure, but they showed that cognitive function improved in individuals who did aerobic exercise. Now, this needs to be replicated. There is a recent review that came out in the Multiple Sclerosis Journal that calls into question the benefits of exercise. And so there's a lot of work now going exploring the importance of exercise to people with multiple sclerosis. But there does seem to be some preliminary evidence that particularly in individuals who are cognitively impaired to begin with, aerobic exercise, if given correctly and at a sufficient level of difficulty, might help their cognition. So to conclude, I'm getting towards the end of my time. Cognitive dysfunction is common in people with multiple sclerosis. Impairment rates can range from 40% in people with relapsing MS to 80 to 90% in people with more progressive forms of the disease. But these deficits are associated with real-world negative consequences, such difficulties as opening containers, making a bed, holding down a job, finding work, will all be impacted by impaired cognition. It is now recognized as part of good clinical care that every person with MS should have cognitive testing if possible. And if resources are limited, the single-digit modality test is a bare minimum. We now know that we can give the SDMT very effectively using computers. Working with colleagues in bioengineering, we have developed a fully automated computerized SDMT in which you do not even need a human tester. And interestingly enough, patients with MS prefer the computerized administration. And this is something that we hope we can now bring into clinics where it can be used by neurologists who are running really busy clinics and who up until now have not had time to bring in cognitive testing. So this is one of the big advances that we're seeing in terms of, where are we going with research? How can we make a clinical impact? There's now a recommendation that people with MS should have periodic symbol digits over time to monitor their change. Once again, this is where the computerized testing can become so helpful. And I should add that there are other computerized versions as well. There's an iPad version of the SDMT developed by colleagues at the Cleveland Clinic. We know that deep gray matter, for example, thalamic atrophy, and diffuse white matter atrophy are linked to cognitive dysfunction. I explained to you why the third ventricle is so important as a proxy for brain markers of cognitive impairment, because this reflects thalamic atrophy, and the thalamus is such a pivotal area in terms of neural circuitry. I've shown you that cannabis use may further exacerbate cognitive deficits, particularly with respect to cannabis THC, but not in relation to CBD. Most importantly, should individuals use THC, if they stop using it, there may well be a significant improvement in their cognition linked to discontinuing the drug. We now know that cognitive rehabilitation is a method of choice in helping people with cognitive impairment, and there are some computerized models of cognitive impairment that can be used to deliver cognitive rehabilitation. But there is a big remaining unanswered question, which I believe is going to grasp the attention of behavioral scientists in the decade ahead, which is, does cognitive improvement in the lab translate into real-world benefits? In other words, if I bring someone into my lab and I give them one of these computerized cognitive rehabilitation programs that run over 8 to 10 weeks, and we show that based on this intervention, they now have an improvement, for example, in verbal memory or the simple digit modality test, to what degree does this translate into real-world benefits for that individual when they leave my lab? And this is what we've got to turn our attention to. How are we going to be able to document in real time and in the real world the improvements that can come about through cognitive rehab? And this is where technology can play such a pivotal role, because this is expanding. Technological advances are expanding exponentially, and we now have ways to monitor people at home and in the community in terms of what they're doing that can give us an indication as to whether our cognitive rehab is proving clinically helpful. And I'll finish with one example of that. As part of my big rehab study, every individual that comes into the study gets an accelerometer. And this is a device that you can wear on your leg or your arm that you keep on every day that tells us how active are you during the day. You know, how much are you getting around? What are you doing? So everybody gets this accelerometer for a week prior to beginning our cognitive rehab study. They go through the study, and at the end of it, they get the accelerometer back again, and we monitor their activity levels for a week. We want to see the degree to which, having come through cognitive rehab, the individual has become more active. And there are many other more sophisticated ways we've got of monitoring activity as well. So this is something for the future. So in conclusion, I thank you for your attention. I would like to thank the MS Society of Canada for funding my research, also the Canadian Institute of Health Research, and then the individuals who've worked in my lab, who have made all the data collection possible, and who help inform science. Thank you for your attention.
Dr. Feinstein, we have some questions that have come in. So if you do have a question, just type your question or comments in the question box. So one of the questions that came in, you did kind of touch on this just a little bit in your summary there. It's about the SDMT test. There's a lot of questions of people wondering if you can give some more information about the app, how people could do the test online. I think you said that it's coming to MS clinics, so maybe you can just touch on that again.
Right. So the test is an easy to do test. It takes only 2 minutes, so it's quick. It's not a stressful test. I want to that's an important point, because there are certain tests of processing speed that can be quite stressful. So it's an easy to use test that people with multiple sclerosis don't mind completing. Our app is being made available to clinics that want it. It's free. There's no cost attached to it. We recently sent the program to the Montreal Neurologic Institute, and there are other places within Canada that are starting to use it. It's not yet out there for people to use at home. I think one has to be careful about that, because my concern is you need to interpret the data. in a broader context. You can't just do the test and jump to assumptions based on what you find on the test. And so I think we're some ways away from being able to give people with multiple sclerosis this test to use at home. We also have to be careful with something like that, because if you do the test over and over again repeatedly, your performance actually gets better because of practice. You just learn how to do it, and that doesn't mean you're getting cognitively. So there are some limitations in terms of use at home, but in terms of a more widespread distribution within Canada, we're starting to do that. That takes resources, and it takes the desire from clinics to get hold of a program like this. But I do believe this is the way. This is the way to the future, because what the test does, in a very easy, straightforward, completely standardized way, it brings an excellent cognitive tool into clinical practice. And the beauty of the computerized version is that every person will get exactly the same test. There's going to be no variability. If there was a human tester in Halifax and one in Vancouver, you'd bring in a certain amount of variance in terms of how the test is done. But with a computer, you get the exact same test every time. It's standardized, and that's a very big plus for something like this.
Thank you very much. Okay, so we have a question about the effects of cannabis on cognition. I know you did touch on that, but maybe can you recap what you said about CBD and THC in regards to cannabis?
Sure. Yeah. So, I have to tell you that not a clinic goes by in which I don't have many patients ask about cannabis. In fact, many arrive already on cannabis. They've gone to a local cannabis clinic and got a prescription for it. I think that's a drug that's got benefits, but like any drug, they're going to be side effects as well. And we in the medical profession need to learn pros and cons, and we're finding our way, because there's not a whole lot of hard empirical data to guide us. I've now done 3 major studies funded by the MS Society of Canada looking at cannabis use in people with multiple sclerosis, and my focus has been on cognition. And we found the same results every time, that individuals who use cannabis regularly, that I mean more than 4 times a week, who've been doing this for many years, are more likely to show cognitive deficits, be they with respect to processing speed, memory, or executive function. A study that we recently completed showed that if individuals stop using cannabis, these cognitive deficits are reversible. So it's a very important point. You stop the cannabis and these cognitive problems get less. I believe that the deficits are more closely linked to cannabis THC. THC is the psychoactive part of cannabis, not CBD. CBD is not psychoactive. And in fact, there's a small literature out there, not in MS, but within the general medical literature, showing that cannabis CBD may offset some of the negative cognitive effects of THC. So I think cannabis CBD is an interesting drug with certain therapeutic properties. I have much greater concerns about THC, particularly from a cognitive perspective, where we've now shown over a number of years in many different studies with a fairly substantial group of people with multiple sclerosis that THC can worsen or cause cognitive difficulties. Adding to the robustness of these data, we've shown, as I demonstrated in my presentation, that the brain activation changes significantly in the presence of THC. So, when you put someone into a functional MRI protocol and you get them to do a study of memory or processing speed, we see a fundamentally different pattern of cerebral activation in those individuals who've been using cannabis. And that gives us a mechanistic understanding for where these cognitive problems come from, because what the fMRI data tell us is that the neural pathways that we know are necessary for intact cognitive functioning become disturbed. The ability of these pathways to activate is impaired. And as a result, people end up with cognitive problems. So, cannabis is an interesting drug. We are learning about it. We are finding our way. But what I tell my patients right now is be careful of regular use of THC, because it may lead to cognitive problems.
Thank you, Dr. Feinstein. Hopefully that answers all the questions in regards to cannabis. This is from Kelly in Toronto. She wants to know what the recommended activities are to increase our cognition. I know you said there are a number of things people can do. Maybe you can go through
Yeah,
that list.
I mean, I think, your brain needs to be active. Everybody's brain must be active. And there's a tendency in people with multiple sclerosis that you can adopt a very passive kind of lifestyle. It's understandable given, your level of disability. But, there are three things to watch out for. Number one, you need some intellectual activity, whether it comes from work or from being on a computer or playing chess or playing bridge or solving problems, whatever, but challenge your brain intellectually. Second point, try and get some physical exercise. Even if you have difficulty walking and you've got lower limb problems, you can still get some exercise, get some light weights, do a bit of exercise, build up a mild sweat, try and get some aerobic activity going, because exercise potentially can also help your cognition. And the third piece is try and remain socially active. And this has become a challenge for people during the pandemic. But, good social connections are good for the brain. They stimulate brain activity. And so the message that I put across to my patients with MS is that be intellectually active, have some physical activity, remain socially active. These points are all good for brain health. This is not a message that's unique to someone with MS. It's a message that's good for brain health across the board. But it becomes particularly germane for people who have cognitive problems, which we see so commonly in multiple sclerosis.
Excellent points there. So stay intellectually stimulated, whether that's working, physical exercise, whatever you're capable of doing, and then as well remain socially active. Very good points there, Dr. Feinstein. Here's another question. This is from Corinne. She's in Barrie, Ontario, Canada. With MS, multitasking can be difficult. She's wondering if you should try to just focus on one thing at a time. What's your recommendation?
Yeah, it's a great point, Kelly. I mean, yes, multitasking can certainly be affected. And the reason is this. I made a point that, the central cognitive challenge for many people with MS is reduced processing speed. You just process information more slowly. And multitasking is often dependent on dealing with a lot of information from different sources quite quickly. And so one can understand that when things start slowing down, when your thinking slows down, when you process information slower, it becomes more to multitask. My message to my patients is that, as you mentioned, try and tackle one task at a time. But sometimes even a single task involves a degree of multitasking. So just try and slow things down. Be aware that your clock is not running as quickly as it once did. If there's an expectation on your part that you're going to get through these tasks as quickly as you were able to a few years back, then you may fail. And with failure comes a sense of despair and frustration and despondency, which further complicates your ability to do these things. So try and slow things down. Try and simplify them. Budget for more time. Accept that it's going to take you longer to do things. So just have a different timeline for completing these tasks. This is what I tell my patients who are still working and they have difficulty at work. When I write letters of accommodation, I'll tell their employees exactly this. Allow the individual more time. Don't load them with multiple tasks simultaneously. Just have a different set of expectations. But if you put these accommodations in place, it's sometimes quite surprising what you're able to achieve. So a different set of expectations and a different timeline can be very helpful here.
Now, I know some of these questions have come in possibly, prior to you just answering them. So this, just to circle back to the exercise here, Dr. Feinstein, there was a question about if you are not able to do any sort of aerobic activity. This is from Jenny in Toronto. Do other forms still make a difference if you're doing swimming, low impact?
Yes, absolutely. All forms of exercise are good for you because they're getting you out, they're getting you to do things. Individuals who have difficulty walking, for example, who can't get onto a treadmill or go for a walk, you can use upper arm strength. Exercise your upper arms with light weights and build up the sweat that way. In our progressive MS study right now, funded by the MS Society, we're dealing with a group of individuals who've got some significant physical disability. The disability score, the EDSS score that we use to rate disability is a 6, which is really quite high. But these individuals exercise on a recumbent bike. So they sit on the bike, it's secure, you're not going to fall off, your feet can be strapped into the pedals, and you exercise this way. And you really can get some excellent exercise, excellent aerobic activity with a task like this. But things like swimming, going for a walk, light weights are all going to be good for you. So yes, do whatever you can. The point is, try and build up a bit of a light sweat. So then you know that it's challenging for you. If you get to that point, then you're doing some really good exercise.
Thank you to everyone who has asked questions. We're trying to get through as many as possible here. So this is from Margaret in Kitchener. Is there a correlation between cognitive dysfunction and the placement of lesions?
Yeah, well, once again, a great question. The answer is yes, but it's complex because we know that cognition is not based on a single part of the brain. We know that cognition is a product of neural networks connecting different parts of the brain. For example, the test that I showed you in my presentation, the test of working memory, where you had to hit the button boxes, repeat it, etc. Well, we know what the neural network is for that particular test. We know that working memory is dependent on parts of the frontal lobe, parts of the parietal lobe, and the connections between the two of them. And so if you're going to have lesions that interrupt this pathway, then you are at risk for developing cognitive impairment. But those lesions can be scattered at different points along the pathway. So you could have an individual with a lesion in the frontal lobe and someone within the parietal lobe, quite far away from one another, but they can show a similar cognitive picture because these lesions are interrupting the same brain network. I showed you an MRI picture in my presentation of the thalamus, and the thalamus is such an important part of the brain because it's an area of deep gray matter, deep within the brain, and becomes a relay center for multiple neural networks passed through the thalamus. And so when the thalamus is affected in people with MS, as it often is, then cognition can suffer as well. And there's now robust data to show that when the thalamus starts shrinking or atrophying, that can be a precipitant for cognitive difficulties. So there are certain parts of the brain that are more important than others, and the thalamus is particularly important. But as I said at the beginning of my answer, cognition is determined by neural networks, and so you can have lesions all over the brain that can cause cognitive problems.
So we have time for maybe one or two more questions here. This is from Micheline, Toronto, Canada. So she is wondering about the difference between memory problems in regards to Alzheimer's and those caused by multiple sclerosis.
Right.
Yeah,
great question. And my patients with MS who are getting older who have cognitive problems ask me this all the time. But there are differences. With Alzheimer's disease, it's relentless. You develop your cognitive problem. There's not a whole lot that can be done to alter that. It just gets worse and worse. That's not necessarily the case with multiple sclerosis. And so, individuals can develop cognitive problems, but if the disease stabilizes, if the person is taking disease-modifying therapy that can bring about a significant improvement in what you see on the brain MRI and control relapses, then cognition may not deteriorate further, that the cognitive decline may stop. And so that's a very difference between MS and Alzheimer's disease. The memory deficits in Alzheimer's are often much more severe and significant than they are in people with multiple sclerosis as well. I mean, Alzheimer's is really characterized by memory impairment. That's like the archetypal cognitive problem in Alzheimer's disease. With multiple sclerosis, yes, you do get memory problems, of course, perhaps not as severe as in Alzheimer's disease, but in MS, the cardinal cognitive features often a slowness in processing speed. Things just slow down. And that also differentiates the cognitive picture in MS from what you see in Alzheimer's.
I think we'll take this as the final question, as we're just about up to 2 o'clock Eastern here, if that's okay with you. Does diet affect cognitive function in people with MS? So we're wondering a conversation about diet, any recommendations? Brain foods?
Yeah, there's a lot of interest. Yeah, there's a lot of interest in diet and wellness and those kind of things, but there's no hard evidence to show that a particular diet is going to improve your cognition. My advice is, eat healthily, try and have a healthy lifestyle, engage in exercise, keep your social contacts, stimulate your brain, those things that I've said already, but bring in a healthy diet. It's undoubtedly good for your physical health. It's good for your coronary arteries. But there's as yet, no evidence in a clinical trial to show that a diet modification is going to improve your cognition. But eat healthily, absolutely.
Well, thank you so much, Dr. Feinstein, for being here today and for doing such important work.
My pleasure. Thank you for the invitation, and I wish everybody well. Stay safe during the pandemic.
And I'd just like to take a moment here to recognize one of our sponsors, MS Connect. Contributing sponsors is Biogen Canada. They have the Abby app that's available to support individuals living with multiple sclerosis. You can visit msconnect.ca to learn more about available products and services and to view the work of up-and-coming MS researchers. So I'm Andrea Dunn. I host the podcast, which is created with support from the MS Society of Canada. I talked about that at the beginning. It's called This is MS. So that's a podcast you can take a listen to. There's 12 incredible episodes there now, and they're available to anyone who has Spotify, Apple Podcasts, wherever you get your favorite podcast. You can subscribe there for free. So This is MS is the podcast. So thank you. This was a wonderful opportunity to be today's moderator. Thank you to everyone for taking the time out of your day to focus on MS research. I think we got a lot out of this session. So enjoy the rest of the conference. Thanks for watching.